Hello, good evening, everybody. My name is Bianca Gonzalez, and I'm very excited to introduce our second webinar within our four-part autism webinar series in honor of one of our foundation's founding doctors, Dr. Herman H. Stone. This is the Riverside Medical Clinic Charitable Foundation's 5th annual memorial event, and we would like to thank our premier sponsor and individual donors, the Riverside Medical Clinic, and Dr. and Mrs. Joseph Sohn, Dr. and Mrs. Nate Olson, and Miss Georgia Hewling. We truly appreciate your support. This webinar, towards the very end, we're going to have a short Q&A session. So if you have any questions or comments, please feel free to leave them towards the end of the session, and we'll make sure to get all of those discussed and answered appropriately. So I would like to go ahead and introduce our speaker for today, Dr. Michael Saito. Dr. Michael Saito is a pediatric neurologist at Riverside Medical Clinic. He received his medical degree from Keck School of Medicine of USC and has been in practice for more than 20 years. I will go ahead and give it away to Dr. Saito.
Good evening, everybody. It's a pleasure to be able to present a clinician's approach to autism. I'm a pediatric neurologist at the Riverside Medical Clinic, and I'd like to describe to you how I make a diagnosis of autism in my patients. First, I think it's very important to understand that autism spectrum disorder, we'll use the abbreviation ASD, is a psychiatric diagnosis. And it is described in the Diagnostic and Statistical Manual for Mental Disorders called the DSM-5 because it's in its 5th publication. This is a guide that was created by the American Psychiatric Association. We need to understand that autism spectrum disorder is a developmental disorder whose symptoms usually appear in the first 2 years of life. So it's a spectrum as described by the psychiatric DSM-5, and therefore there may be a spectrum of severity in affected individuals characterized by problems with communication, with their family and peers, and even at the school level, but it also must include symptoms of repetitive behavior and restrictive interest in order to make that diagnosis. These symptoms also cause a dysfunction in the child's development in the home, school, and possibly even work when the patient is an adult. The incidence has been described as common as 1 in 59 children by the CDC Autism and Developmental Disabilities Monitoring Network. It's reported to occur in all racial, ethnic, socioeconomic groups. It's 4 times more common in boys and girls. We need to understand that 1 in 6 children in the United States have a mild to moderate developmental disability. So the symptoms of social interaction and communication include inconsistent eye contact, where the child may look away from you as you're speaking to them, or they may just stare at the bottom part of your face. There may be also problems in gaining the child's attention, or even for the child to acknowledge what his or her name is. The children often fail to share in enjoyment with others and tend to play alone and have episodes of gleefulness with hand flapping sometimes or laughing to themselves. They often have problems with engagement and developing a conversation because they don't have that animation and facial nuances such as nodding of the head or raising of the eyebrows or opening of the eyes widely when when other kids are excited. They have an absence of this candidness. They also have restricted interests in allowing others to share their interests. So they may want to just speak about Star Wars, and any other interests are not acknowledged during a conversation. And so a lot of other children just lose interest in speaking to the child. They often have this mask like facial expression because they don't know the nuances of how to engage people and how to potentiate a conversation. Sometimes the voice may be expressionless or often a sing-song like voice. It may also be a very light whisper when they answer only in single words. They also seem to have this inability to understand the other person's point of view. They may not understand inferences or humor, such as sarcasm, and they just can't get where the story may be headed toward. The other symptom category that autistic children have problems with are repetitive behaviors such as echolalia, where they just simply repeat the sentence that you just, or the question that you just asked, such as, how old are you? And they just repeat it. Sometimes I get a sense that they're having problems processing the question, so they just repeat it. But there are children that simply just repeat almost like a parrot would a question or a sentence. Their interests are very restrictive sometimes, and they tend to embellish certain subjects, such as details and numbers. Uh, for example, specific cars that they like. They know exactly the year that they were manufactured, how many were manufactured, and they're sometimes experts in this certain field. They may be overly fascinated by moving objects such as wheels of the cars that they line up. They may line up cars in shape, color, and there may be a specific order to it. And they may be very upset by changes in the order. If you pick up a car and move it to the end, they may become very upset. Also, they may be upset by just changes in routines, such as when school lets out, or even if you change the route of the car that you're driving on the way home to, let's say, your house or grandma's house, and you take a different route, it could spark a meltdown that could last for 15 minutes or even longer. Some of the children may be so upset that sometimes the parents are scared that the neighbor may even report them to Child Protective Services because they're screaming so loudly, and they may be throwing objects or smashing doors. Some of the children may be very sensitive to sensory input, such as mechanical noises from blenders or vacuum cleaners. They may become upset from clothes that have elastic belts or leggings. They Some children may like very loose clothing that doesn't cling to their body. Uh, some children may not like to be touched on the head or other parts of the body, and they some children may have very restrictive diets because of different textures, flavors, or smells that they have an aversion to. So, in making the diagnosis of autism spectrum disorder, we often start with the general screening tests that are recommended by the American Academy of Pediatrics, and these occur at 9 months, 18, 24, and 30 months of age. And if a child fails these screening tests, the pediatrician may refer the child to a subspecialist. So these may include developmental pediatricians who completed a fellowship of a year or 2 years of developmental pediatric academia and passed a licensing exam. A pediatric neurologist like myself, or a child psychiatrist who went through adult psychiatry training and then took extra training of 1 or 2 years in child psychiatry. Child psychologists are another subspecialty that can also make the diagnosis of autism. PhD child psychologists are licensed to be able to administer tests and make the diagnosis of autism. Neuropsychologists who usually work at a university setting such as UCLA or USC may also make the diagnosis. Any test or battery of tests of making the diagnosis of autism should include observational schedules, history from the parents, caretakers, teacher, and other cognitive tests are very, very important in making the diagnosis. In general, observation and family history are the most important components in making the diagnosis. So some risk factors for autism include siblings who have also been diagnosed with autism and other genetic conditions such as Down syndrome, Fragile X syndrome, which is the most common cause of mental retardation in males. Also, medical diseases such as tuberous sclerosis, which is a disease that affects the skin as well as the central nervous system in children, and the child may have horrible seizures, as well as the psychiatric symptoms of autism. So you can see that medical diagnoses are different than the psychiatric diagnosis of autism. So you may have both. So a female who has a small head and has repetitious wringing of their hands, such as those in Rett syndrome, may also have autism, which is a psychiatric diagnosis. And very low birth infants are also at risk for developing autism sometime in their lives. So as we discussed, autistic children may also have problems with the selective diet. And I know of some of my patients may only eat chicken McNuggets, and they always have to be from McDonald's. They have to have the coating removed, and or other possible meals, maybe just a spaghetti made from Chef Boyardee or some other uh, uh, type of food. And some of these children have to have supplemental vitamins as well as maybe even a pediatric formula, such as Pedicare, um, sleep, Pediasure. Sleep may also be a problem in many of my autistic kids, and we may need to use melatonin or some other sleep aid so that the mother can sleep and then the child's not as irritable. But sometimes the autistic child may be very irritable to the point where he's aggressive toward his parents or even toward himself and hit his head on the ground or hit his fist into his face, in which point you have to get a helmet for the child. So these are very serious problems. Some of the tests that I might order on a child who I'm being consulted for autism may include blood tests when I have a suspicion for maybe a metabolic disease where there's an enzyme defect and metabolites are building up in the child's body and brain and giving the child autistic features. Other tests that are very important, I believe, are genetic testing. I think that uh, most children with a diagnosis of autism probably should have genetic testing, and we'll go into some of the reasons why. Possible imaging or EEG may be necessary in children who I suspect may be having seizures and have regression of development and also having autistic features. So I have had patients that had multitudes of seizures, maybe even while I was observing them. And I knew that I had to do an EEG and start the patient on anticonvulsants. An EEG is a recording of the electrical activity of the brain and would help me in making a diagnosis of seizures. Children who are of school age may need psychoeducational testing by the school psychologist who may go on to uh, make who may go on to place the child by using a diagnosis of autistic like behaviors in the child so that the child can be placed in special education or an autism program, which would help the child if they're at high risk. A careful physical examination and neurologic examination is also necessary because we need to check the skin to make sure that there are not hypopigmentation uh, involved or hyperpigmentation in which there may be uh, coffee colored spots on the body uh, or even raised spots on the body that may make me suspect that the child may also have a central nervous system problem. So careful skin and physical exam is very, very important. Uh, we need to, on the physical examination, examine the face, look for certain abnormalities of the nose, the ears, how widely the eyes are placed. We may even examine the fingers and the chest for other abnormalities, as well as the length of the child's limbs. In a neural exam, I'm examining for hypotonia, where the child may be floppy, or hypertonia, where the child may be rather stiff. An important part of the exam should be a cognitive evaluation, where we should examine the language skills of the patient, i.e. the expressive language and receptive language of the patient, and get age levels for personal, social, fine motor, and gross motor development. So some of the common tests that are used in the diagnosis of autism are the Autism Diagnostic Observation Schedule, which is used to quantify some of these symptoms of repetitive behavior or communication that we observe during the examination. A behavioral assessment system for children can also quantify the dysfunctional behavior. And the Guillaume Autism Rating Scale, as well as the Childhood Autism Rating Scale, are questions that help us quantify certain symptoms that are given from the history of the parents, the teacher, or other caretakers. In school, the Wechsler preschool and primary scale of intelligence may be helpful for putting a child who uh, scores poorly in a high risk program or early intervention program. So all of these are good tests, but every psychologist or specialists have their own recipe of scales. So I'd like to move on to structural variation of chromosomes in autism. We all know now that we have mapped the human gene, the genome, and so we can compare some of our children's DNA to the normal DNA found in the human genome. And there's no specific chromosome defect, but there are many well-known associations recognized in as high as 10% of the cases. Some of the common ones we already spoke about: the Fragile X, found on the X chromosome, that is donated by the mother, Rett syndrome, which is the MECP2 gene abnormality, as well as tuberous sclerosis. And we may find some detectable chromosome abnormalities in as high as 7% of the cases that I've tested. Some of the most frequent anomalies are derived from the mother, and there's duplications in certain sections of chromosomes found in the 15th, 22nd, the second chromosome, and also portions of the X chromosome called the NLGN3 and NLGN4 portion of the X chromosome. As the first presenter discussed, applied behavioral analysis is extremely important to help correct dysfunctional behavior. Almost all children also need speech therapy because, by definition, they have problems with communication. Occupational therapy is also very important because feeding problems are taken care of by the occupational therapist, and also some of the children may have problems with fine motor, such as writing, and also even with opening bottles, etc. Physical therapy may be important in some of the cases because some kids with autism have a problem with personal space, and the physical therapist can help them be more aware and they won't be as clumsy. So at this point, I'd like to conclude the academic portion of the presentation, and I'd like to open to
Thank you so much,
questions.
Dr. Saito. So yeah, if anybody has any questions or comments, please feel free to leave them in the chat box on the right-hand side. We have a couple of minutes for a Q&A session. I did receive a couple of questions beforehand, so I do want to ask you one, Dr. Saito. One of the questions was, are medications useful in treating the behavioral problems of autistic children?
I feel that a lot of the children who have autism have obsessive-like qualities. They may also have certain levels of anxiety, and they also may be somewhat distractible. So in those children who do have problems with anxiety and obsessive compulsive disorder, a Prozac-like medicine may be helpful. So Prozac is FDA approved for children who have autism, and also those kids who have problems with hyperactivity and distractibility. I may offer a stimulant in very, very low doses. So all of these medications would be started with very, very low doses. Those children who have self-mutilative behavior, aggression toward their parents or other children, may also be treated with FDA-approved atypical antipsychotic medication, including risperidol and also Abilify. I'd also like to make a statement that vaccinations have been proven not to be causing autism.
Thank you. I do have another question from Jeannie Caballero, and she would like to know, how do you determine if your child is nonverbal or just speech delayed, and what is the difference?
Well, a nonverbal, so there's a spectrum of expressive language problems. So a nonverbal child has no words, does not sign, and would not point to what he wants. Those children have a poor prognosis because they do not point what they want, which is sort of a form of communication. Some children may have expressive language delay because of, let's say, social anxiety, or what we call selective mutism. So some children may be able to speak to their parents, but not speak in class. And that's a form of anxiety. We also have to make a distinction between receptive language and expressive language. So those children that don't speak, but you ask them to pick up a blue cube and put it in a yellow bucket, have a much better prognosis because they have good receptive language and they can follow your direction. So I know that that child has a certain level of cognitive ability. What was
What
the
is
last
the
part of the
difference?
question?
I believe you.
So the so nonverbal and just speech delay. Speech delay would mean that that child is able to say one or two words, let's say at 2 years of age, but that's a 12-year goal. That's a that child is delayed by a year. So if that patient has been assessed at that, I would say that given other symptoms, I would say that that child may be at risk for uh, autism, but they should go through a proper screening test.
Thank you. Another question that I have from one of our viewers, Gloria Lopez Hicks, she would like to know, is a mother's drug addiction through pregnancy a factor in a child's diagnosis of autism?
I think that's a really good question. And it really depends on actually the drug that was used during pregnancy. So, an opiate, for instance, cause the same amount of brain damage as as speed, let's say. Um, and so, those patients that abuse uh, speed, um, like high dose amphetamine, methamphetamine, the child's brain, while it's developing, may uh, experience small strokes that would predispose that patient to learning disabilities, behavioral abnormalities, and possibly qualify the child for autism, but they have to have all the symptoms that we discussed in order to make that psychiatric diagnosis. Some of the children who have been exposed to drugs uh, may just have anxiety, may have uh, intellectual disability, but do not satisfy the diagnosis of autism. But certainly, I have whole families whose grandparents are now taking over the care of the drug abusing uh, mother, and many of them may have autistic features.
Thank you. One other question that I do have is, do autistic children suffer from other illnesses?
During my talk, I mentioned that there the medical diagnosis, let's say kidney failure or congestive heart disease, is different than the psychiatric diagnosis of autism. So you may have, let's say, for example, experienced a stroke or some um, brain trauma from a motor vehicle accident that may cause problems with learning, but it may also cause problems with mood, such as depression. So someone may have a stroke, but also have depression. So someone may also have, so a child may also have a congenital brain malformation and then have autistic features, autism, and qualify for that diagnosis. I have a patient who was fine and then developed a tumor in the cerebellum. The tumor was removed and the child developed autism and fulfilled that diagnosis. So we can have medical diagnoses and we can have autism coexist.
Thank you. Another question that we do have from Jeannie Caballero is, how does low birth weight contribute to autism?
So premature infants may experience cerebral hemorrhaging or intraventricular hemorrhaging, meaning that when the brain is forming at very early age, let's say at 22 weeks of age, there's this very fine uh, net of vessels that occur inside the cavity of the brain. It's called the ventricles. These this very fine net may cause hemorrhaging due to increased blood pressure or a drop in blood pressure and then a quick return of that blood pressure back to normal, and then the intraventricular hemorrhage may occur. And so this may predispose the patient to psychiatric problems as well as cerebral palsy. So you could have cerebral palsy, which is like a stiffness in the limbs with we call hypertonicity. And then develop abnormalities such as seizures, as well as the psychiatric diagnosis of autism. So in that way, low birth weight children are very delicate, and because of the complications, can develop autism later.
Thank you. We have another question from Veronica Manjares, and she would like to know, you mentioned that some children with autism may hurt themselves. Is hurting themselves because there is no language or something else?
You know, that's a really good question. I have to say that everyone who's asked the question today, it is all of these questions are very thoughtful. And I would say that those children that do hurt themselves, I see a big change once they are able to speak, or they're able to sign, or they're able to point. It seems that the mom is correct in that. So Veronica is correct that some of the self-mutilative behavior is due to frustration. And a dramatic change once they're able to communicate. That's why speech therapy is very, very important. And so even children can learn to communicate through a storyboard, like some of the speech therapists are using on iPads, and also signing. So get your children into a good speech therapist as soon as possible, because aggressive therapy has been shown to help these children immensely, and their prognosis is improved greatly.
Thank you. And then another question we have is, are dietary interventions helpful to autistic children?
That is also a very good question. Gluten-free diet has not been shown to be helpful um, uh, in studies with children who have autism. Red dye, um, sugar has not been shown to cause autistic behaviors. I know that anecdotally, a lot of my moms tell me, and so if the gluten-free diet is working for you, that's great. If sugar restriction is working, then by all means keep it up.
Awesome. Thank you so much, Dr. Saito. I think that is the end of our Q&A portion of the webinar. So I just want to go ahead and thank you so much for your presentation today. I want to thank everybody for attending today. And this PowerPoint will be sent to everybody that registered today, so no worries, you will be receiving all of this information. And yeah, once again, I just want to go ahead and thank Dr. Saito again for being part of our second webinar within our series. And just keep an eye out for our next upcoming webinars. They are every Tuesday of this month, so they are 2 left this month at 6 p.m. Have a great night, everybody. Thank you, Dr. Saito.
Good night.